Hello, coders. I'm sorry about part one being so short. My computer crashed and I had to pick up with a new Path and Lab. So we finished off with talking about the definitive drug classes. And then again, right here it says continue on page 516 because when we get to all these pages in between, this is giving us a breakdown of all the different drugs that we might end up dealing with. And so again, the definitions and acronyms, conversion listing, this is very, very helpful. This will also be helpful, again, with knowing more about what is in Path and Lab. The guidelines pick up on page 516. Okay, and it goes, when the same procedure is performed on more than one specimen, like blood and urine, and the appropriate code is reported separately for each specimen type, use modifier 59. So again, we could be getting blood and urine, we could be getting mucous membranes and hair, we could be getting any combination of different types of body fluids. So if we're going to run the test more than once and more than one type of specimen, we're going to use modifier 59. Now, again, this could be because we saw a little bit of something in urine, so we want to get a more definitive in blood, or this could be because the doctor is looking for something specific in one of the specific body fluids. It goes on to say, drugs or classes of drugs may be commonly assayed first by a presumptive screening method, followed by a definitive drug identification. Okay, so the presumptive screening is trying to figure out what the drug is that's in the system. So these are just following methods that if you end up working for Path and Lab, this is what they can do with certain pieces of equipment. What I want to be clear about is not every lab has all these different pieces of equipment. You will know if you work in Path and Lab what type of equipment they're using. So presumptive methods include, but are not limited to, immunoassays like IA, EIA, ELISA, urea, EMIT, FPIA, etc. Enzymatic methods, which are things like alcohol dehydrogenase. Chromatographic method without mass spectrometry, TLC, HPLC, GC, etc. Or with mass spectrometry without adequate drug resolution by chromatography. This is things like MSTOF, DART, DESI, LDTD, and MALDI. We also will see LCMS and LCMS/MS, or mass spectrometry without adequate drug resolution by chromatography, may also be used for presumptive testing if the chromatographic phase is not adequate to identify individual drugs and distinguish between structural isomers and isobaric compounds. So again, they're letting us know that certain types of testing may or may not show what the actual drug is. And what we're really looking for here is just what they're saying, the isomers and the isobaric compounds. These are the compounds within these specific drugs and alcohols that we can distinguish that is different from other ones, okay? All drug class immunoassays are considered presumptive, whether qualitative, semi-quantitative, or quantitative. Methods that cannot distinguish between structural isomers such as morphine and hydromorphone or methamphetamine and phetamine are also considered presumptive. Again, presumptive meaning we presume what it is, but we don't have a definitive identification. It goes on, definitive drug identification methods are able to identify drugs and distinguish between structural isomers, but not necessarily stereoisomers. So again, they might be able to say, yes, this is a cannabinoid, yes, this is an opioid, but they might not be able to distinguish exactly what type it is. So definitive methods include, but are not limited to, gas chromatography with mass spectrometry, any type, single or tandem, and liquid chromatography, mass spectrometry, any type, single or tandem, and excludes immunoassays, the IAs, the EIAs, the ELISAs, the RIA, the EMITs, and the FPIA, and enzymatic methods. So again, presumptive methods tend to use certain methods, definitive methods use others. And these are things that the machines themselves can do based upon what is ordered by the physician. So for chromatography, each combination of stationary and mobile phase is to be counted as one procedure, because again, they're trying to distinguish this information. So they're trying to say, okay, what drug is this? Now, what specific drug is this? Now, drug or classes of drugs may be commonly assayed. First followed by the definitive drug identification method. The methodology is considered when coding presumptive procedures. Each code, which is the 80305, 306, and 307, represent all drugs and drug classes performed by the respective methodology per date of service. Okay, so it's per date. Each code also includes all sample validation procedures performed. Examples of sample validation procedures may include, but are not limited to, pH, specific gravity, and nitrate. The codes 80305, 306, and 307 represent 3 different method categories. So what these are is these are very specific drug tests, and we're doing multiple drugs at one time. So let's go through and see what they have. Code 80305 is used to report procedures in which the results are read by direct optical observation. The results are visually read. Examples of these procedures are dipsticks, cups, cards, and cartridges. Okay, and so basically these are things where the person is giving us a urine sample and we are able to visually read positive or negative for 80305, okay? And again, it's per date of service, not per number of drugs testing. And a lot of times these cards and cartridges will have like 5 of the main drugs, I should say 4 of the main drugs plus alcohol, so that again, they can read this. And these usually only take about 5 to 10 minutes to read total. So it goes on. Report 80305 once, irrespective of the number of direct observation drug class procedures performed on results on any date of service. So again, if the cup or cartridge can do 10 drugs, then it's 10 drugs. It's still 80305. If we're doing 3 drugs, it's 3 drugs. Okay, so it's what is inside, but really it's the methodology. In this case, it's again read by direct optical observation. And again, that is in the code descriptor that we'll look at. So code 80306 is used to report procedures when an instrument is used to assist in determining the results of a direct optical observation methodology. Examples of these procedures are dipsticks, cards, and cartridges inserted into an instrument that determines the final result of an optical observation methodology. Report 80306 once, irrespective of the number of drug classes, procedures, or results on any date of service. And again, this is an instrument that is used to assist. So 80305 is direct optical observation. We are looking at it with the naked eye because there's an indication that we can easily see, like the strip turns pink, okay? Versus 80306, they're using an instrument to assist in these. Code 80307 is used to report any number of devices or procedures by an instrumented chemistry analyzers. These are going directly into a machine, okay? And this is where we're going to get the different methodologies. Again, it's going to go on, the immunoassays, the chromatographies. I'm not going to read through all of those again. But again, as it goes on here, some of these methodologies may be used for definitive drug testing also, but for the purpose of presumptive drug testing, the presumptive method is insufficient to provide definitive drug identification. Report 80307 once, irrespective of the number of drug class procedures on result on any date of service. So the difference between these, as we're going to see, 80305, capable of being read by direct optical observation only. 80306, read by instrument-assisted direct optical observation, or by instrument chemistry analyzers. Okay, and again, these are all per date of service. So it doesn't matter how many we do as long as we're doing it on that date. Okay, and so this is one of the things we have to be careful. These are presumptive drug screenings. So these are going to be things like pre-employment screenings. These are also going to be screenings when people are going through like mental health therapies for alcohol and drug addiction and things like that. So this is also, I should say, going to be used for people on chronic pain meds as well, to again make sure that they are not taking anything extra that is not in the contract with their doctor. But again, this can be done for a variety of purposes, and the reason why these codes were added, as you can see here in 2017, is because these cups and cartridges are becoming more and more readily used, and they're easier to use than running normal blood tests. But if we have to run a, quote, normal blood test for a drug, that comes down here, okay? That starts at the definitive drug testing. So definitive drug identification methods are able to identify individual drugs and distinguish between structural isomers, but not necessarily stereoisomers. So again, we can narrow it down to the exact drug, but again, there are some limitations. Now, they go on to remind us that definitive methods include, but are not limited to, gas chromatography with mass spectrometry, liquid chromatography with mass spectrometry, and they exclude the immunoassays and the enzymatic methods. So again, we tend to use the immunoassays and enzymatic methods in the presumptive drug screening. We tend to use the spectrometry and chromatography in the definitive, just different ways of looking at the sample. The definitive drug class listing provides the drug classes, their associated CPT codes, and the drugs included in each class. Each category of drug class includes metabolites, if performed, except stereoisomers. It is reported once per date of service, okay? Metabolites not listed in the table may be reported using the code for the parent drug, okay? So again, what general drug class does it fall under? Drug class metabolites is not reported separately unless the metabolite is listed in a separate category in the definitive drug class listing, like a heroin metabolite. Okay, so again, what do we know about what is in the sample? Now again, drug classes may contain one or more codes based on the number of analytes. So how many things are we analyzing? For example, an analysis in which 5 or more amphetamines or amphetamine metabolites would be reported with 80326. The code is based on the number of reported analytes and not the capacity of the analysis. So again, let's take another circumstance. Someone went to a party, they ingested some pills, and then they passed out. They were then brought to the hospital. We have very little information to go on, but one of the people who brought that patient in said, well, there was some type of amphetamine going around. So again, we might want to look for the most common amphetamine. You know, sometimes we know exactly what we're looking for. Other times we have to see, okay, which amphetamine, what are we looking for? Especially for things like amphetamines, because they're mixtures of things. They're uppers, but they tend to be in like a pill form, and they can mix them with other types of drugs and other substances, which can, of course, cause reactions. Now, the biggest thing here, definitive drug procedures that are not specified in 80320 to 8032373 should be reported using the unlisted definitive procedure codes 80375, 76, and 77 unless a specific analyte is listed in the therapeutic drug assays or chemistry sections. So again, they're telling us we do have 3 codes to use if we don't have the drug. Again, it could be a new street drug. Okay, so we need to be careful. What are we looking at? So when it comes to these codes, again, we're going to see things. So like analgesics, non-opioids, we can look for 1 or 2 analytes, 3 to 5, 6 or more. For antidepressants, for the serotonergic class, again, 1 or 2, 3 to 5, 6 or more. And you can see we've got all different antidepressants, tricyclics. Then we have antiepileptics, antipsychotics, barbiturates, benzodiazepines. So we even have cannabinoids, natural, and although it's not on this page, 80350 to 80352 is cannabinoid synthetic. Recently, you might have noticed that there was quite a few articles out there about fake marijuana or synthetic marijuana, because basically what they do is they take a whole bunch of chemicals and they boil them down and they mix them with leaves, you know, like oak leaves and things like that, maple leaves, and then people smoke them. The problem is we don't know what's in that mix. It's not marijuana, it's a synthetic high, and the problem is that the last batch that went out, I think it killed 3 people and it poisoned 100 because someone decided it would be a great idea to add some rat poison into it. So again, this is why we have all of these differences. Again, we have cocaine, we have heroin, ketamines, methadones, opiates, opioids, oxycodone specifically, other sedatives, skeletal muscle relaxants, tramadol. So again, we have all of these different drug classes. And if we're not sure if the drug that they've just listed is in one of these drug classes, the first thing that we can do is look on pages 519 to 520 to see where they might fit in. And the other thing is we might have to do some online research, especially if these are new straight drugs. So, that's one of the things that we want to kind of keep in mind is, do we know what we're looking at? If we don't, 803, 75, 76, and 77 are used unless the drug falls under the therapeutic drug assays or the chemistry section. So again, we want to be careful. Now, pages 519 going into 520 is the definitive drug class listing, and then we start with what we call therapeutic drug assays. So again, therapeutic drug assays, as they say, are performed to monitor clinical response to a known prescribed medication. Okay, the material for examination is whole blood, serum, plasma, or cerebrospinal fluid. Examination is quantitative. We're looking at how much. Coding is by the parent drug. Measured metabolites of the drug are included in the code if performed. Okay, so this is making sure someone is A, taking the medication, and B, how much is in their system. So, we have things like amikacin. We also have things like vancomycin, which is, one of the antivirals, I believe. But we also, if you look, like 80155 says caffeine, and you're like, why would we look for caffeine? Well, one of the things that we do for premature babies, because the lungs are one of the last organs to fully develop, is they can be given a mixture of drugs, which includes caffeine, that helps them breathe a little bit easier. But again, it has to be very finely tuned. These are done by pulmonologists and respiratory therapists, and they have to keep checking on a daily basis to make sure that the caffeine levels in that baby are kept at a very clear level. We're not going too much, we're not going under. And they can use these for older children too. It's just more often used for babies. We also have things like digoxin, which is for congestive heart failure. We have things like lidocaine, which is also used for pain. We have lithium, which is used as a mood stabilizer. And so again, we're looking for how much is in the body. Okay, when you get to page 521, you'll notice all of these. And that's why I put page 517, just like I do in the medicine section when cardiology got moved. So basically, this is what happened. For 2016, 2017, they decided they were going to update basically all of our testing for drugs and add a whole bunch of new codes. And just like what has happened in other sections like E&M and some places in surgery, there was just not enough room in the book. So what they did is they put the codes where they were next available, which happened to be after the therapeutic drug assays, and then they resequenced them starting on page 517. And that notation will certainly help you if you're doing your CPC and you get to this section and you go, where are the codes? The codes start on page 517. So let's remember that. Now the next set of codes is the evocative suppression testing, and you can look these up under evocative suppression testing. They tell us the following test panels involve the administration of evocative or suppressive agents and the baseline and subsequent measures of their effects on chemical constituents. Okay, so what they do is they have the person come in and then they take a baseline blood test. So they take their blood and they run it. Then they give them an agent. Now, these are all, when you look at them, they are all different types of hormones. So we want to either evoke or suppress what's going on in the body. So basically, these are for people that are having a hyper or hypofunction of at least one or more of their endocrine glands. So here's the thing. What we want to do is we want to get that baseline first, then we're going to give them a drug that will either evoke or suppress, put them in the opposite function so we can see how the body reacts to that drug. So this is where it gets important. These codes are to be used for the reporting of the laboratory component of the overall testing protocol. For the administration of the evocative or suppression agents, see hydration, therapeutic, prophylactic, diagnostic injections and infusions, and chemotherapy and other highly complex drugs or highly complex biological agent administrations. Okay, so again, These are just the blood tests. We also, remember, anytime we're injecting someone with something, having them inhale a drug, we have an administration code. And those administration codes start at 96365 and go to 96376. Again, dependent on how they get it into the body. Again, is it an injection? Is it intravenous? Is it intraarterial? Is it intramuscular? Okay, how are we getting it into the body? So keep in mind, these are always paired with another set of codes, depending on who you're coding for. If you're just coding for the lab, then you definitely have to code for the administration of the agent and the agent we gave them, because we want to get paid for everything. Now, in the code descriptor, where the reference is made to a particular analyte, like cortisol 82533 times 2, the times 2 refers to the number of times the test for that particular analyte is performed. So let's look down here. Okay, so 80400 ACTH stimulation panel for adrenal insufficiency. So we're doing cortisol, which normally in the book would fall under code 82533 times 2. Again, these are what I call mini panels, okay? So we looked at our regular health panels at the beginning in part 1. These are mini panels that we do. So again, we use the code 80400 when we test the patient for cortisol twice. The first time is the baseline, and the second time after we give them a stimulant to stimulate the adrenal glands. And again, you can look for, it's for adrenal insufficiency. We also have one for 21-hydrogenase deficiency, which again looks at cortisol and the 17-hydroxyprogesterone as well. And again, these are different deficiencies that are happening in the body, or we're trying to evoke what's going on. So again, these are all different hormones and they're all grouped together. So again, we would not code 82533 times 2 and 83498 times 2. We would code just 80402. Remember, when the codes are not in bold, they are not something that we can code in Path and Lab. It's just giving us a hint saying, hey, if you are generally looking for the cortisol code, you want to go to 82533, just like they do in the general health panels. So the big thing here is we look under evocative suppression, and then what are we looking at? We have things for aldosterone, we have calcitonin, we have, corticotropic, we have the renin stimulation, rapid anterior pituitary evaluation, all these different things. And again, we're always trying to either evoke or suppress what's happening in the body. So I just want to point out, although I do not have a picture of it, we have codes that we can do them again up to things like 6 times. For instance, 80416, renal vein renin stimulation panel. This panel includes the following: renin 84244 times 6. So again, keep in mind that some of these tests are going to take multiple hours to do. So again, we need to know what happened during that testing, because we are going to get the information after the patient has left. So the next section is the consultations for clinical pathology. There's only 2 codes here, but this is important. Again, it tells us a clinical pathology consultation is a service including a written report rendered by a pathologist in response to a request from a physician or qualified healthcare professional in relation to a test result requiring additional medical interpretive judgment. So again, a physician from another area has asked a pathologist to look at information and to write a report. Reporting of test results without medical interpretive judgment is not considered a clinical pathology consultation. Remember, consultations have to have an actual write-up. That's what a consultation is. The differences between these is whether or not we're going to give the pathologist all the patient's history. Sometimes we want to, sometimes we don't, and sometimes we can't. So for instance, we have a patient comes in, they're unconscious, we have no ID on them, we know nothing about them. That's going to be 80500. It's limited without review of patient's history and medical records because we don't have any. However, if the patient's been in the hospital for, let's say, 2 weeks and they can't quite figure out what's going on with, let's say, an infection that they have, then that would probably be more of an 80502, a comprehensive for more of a complex diagnostic problem. So again, this is one of those things that it's very specific but it has to be a written report. If there's no written report, then it can't be coded. So if a hospitalist goes up to a pathologist and says, hey, I just want your opinion, and they just talk about it, that is not this consultation, okay? Just like we can't code that stuff for E&M either. There has to be something written down, and that they have reviewed information about the patient, and we need to have that record to be able to code for a consultation. Now, the next section is urinalysis. We have a couple different urinalysis codes. Again, we look up urinalysis. We need to know how we're performing it, okay? So we basically need to know whether or not we're using a microscope. So the main code is urinalysis by dipstick, tablet reagent, or bilirubin. For bilirubin, glucose, hemoglobin, ketones, leukocytes, nitrates, pH, protein, specific gravity, urobilinogen, and any number of these constituents. Now, this is non-automated with microscopy. So what this means is it could still be a dipstick or a tablet, but then someone's looking under a microscope. That does not happen in most offices. Most offices, what's going to end up happening is that they're just going to use it without microscopy. So that's on the next page. We're going to get to that in a second. So again, it depends. If this is a urology office, then they might use a microscope in the office. We need to know what's going on. 81001 is automated with microscopy. That's usually the one where they send it out to the lab because the lab is doing it in automated fashion. And on the top of the next page, 81002 is the most common in the office because that is the non-automated without microscopy. So again, in this case, all we're doing is doing a dipstick or putting a tablet in and seeing what the visual result is. I also want to point out that we also have code 81025, the urine pregnancy test by visual comparison methods. Again, most doctors, if it comes out positive, they will then run the blood test for pregnancy, looking for the progesterone in the body. So again, lots of different urinalysis that could be happening, and it all depends on what office you end up working in. Again, if you end up working in an endocrine office, endocrinology, they might have a microscope where they look under when the patient comes in. And now we get to molecular pathology. So molecular pathology, all of these codes came about for 2012. That was the first year they came into the book. And as I was saying in part one, most labs cannot run these tests. These are very specialty labs that are looking directly into the genes. Okay, so let's kind of look through the guidelines and then I'll tell you a little bit more about what happened. So molecular pathology procedures are medical laboratory procedures involving the analysis of nucleic acids like DNA and RNA to detect variants in the genes that may be indicative of germlines, which are also known as constitutional disorders. So those are family histories that's going through the germline, or somatic, like neoplasia, like cancers, conditions, or to test for histocompatibility of antigens, like HLA. Code selection is typically based on the specific genes that is being analyzed. Genes are described using the Human Genome Organization, or HUGO, approved gene names that are italicized in the code descriptors. Gene names are taken from tables in the HUGO Gene Nomenclature Committee, which is known as HGNC, at the time the CPT codes were developed. And then it goes on to talk a lot more about the Human Genome Variation Society and all of this. So let's go back. So we're looking into our DNA. We're looking into the DNA and the specifics in the DNA. So if you remember back to your anatomy and physiology when we talked about DNA, we are looking for any problems. So for instance, a genetic disorder that we're all very familiar with is Down syndrome, trisomy of the 21st gene, where there's an extra gene that's there. This is going even deeper. This is going past the chromosomes. This is going into the DNA itself. This is not just looking at the chromosomes. This is looking inside the chromosomes to get the DNA. And so one of the big things that we're going to look for here is we're going to look for additions, deletions, duplications, reversals, and what they call a ring. So Again, there can be additions to a genetic line that shouldn't be there but somehow got there. There can be deletions where there's genes that are just missing that should be there. There's duplication where DNA is supposed to be opposite. Again, remember, think of it like a winding staircase, but instead of it being a staircase, what it really is a winding ladder. Okay, and each of the footrests going across the ladder, on either side, there's a gene that's associated with it, and the gene on the opposite side should be the opposite. Remember, we have A, C, T, and G. So again, the problem is when there's duplication, it's a duplicate, meaning it's the exact same, which also can provide problems. We also have issues where basically there's a reversal. So if it's supposed to be like A, B, C, D, it's A, D, C, B. Okay, where it flips and it's in the wrong area. And then we have what I was talking about, the ring, which is when part of a chromosome itself, the bottom just breaks off, and because of that, the chromosome creates a ring when it shouldn't. So we're looking into these chromosomes, into the genes in the chromosomes, to try to find all these different disorders. And again, they're looking for germline ones that run in families, and also ones that run in certain backgrounds. You know, Tay-Sachs tends to run in Mediterranean-based backgrounds. You know, for instance, my family line is mostly French, so it's not something that we're worried about. We don't have Tay-Sachs in our genetics, you know, but there are other conditions that come with certain backgrounds in certain areas of the world. And so we're trying to find the germlines, and we're also trying to find the somatic ones, cancer. We're trying to figure out how can we identify these. And one of the best known ones that almost everyone has heard about at this point is what we call BRCA1 and BRCA2. And that is actually in our code book. BRCA1 and 2 is actually code 81211 to 81213. And that's when we're looking for the breast cancer gene and we're looking for the ovarian cancer gene, specifically the familial line. So again, we're looking into the family history of this. And these are the types of tests that people like Angelina Jolie had done. Now, hers came back positive. Here's the problem with that. Just because it comes back as a positive test does not mean that you will get cancer. What it means is you have a much higher probability of getting cancer, okay? So that, you know, when it comes to things like BRCA and other cancers, it's a probability, okay? Versus other testing is for other types of genetic disorders. And again, I'm not going to read through all these definitions. They are well worth a really good read. And I will be honest with you, you may want to break out a dictionary, because a lot of these terms in here are ones that we don't hear of that often. And it's interesting. So it's not that you should look into this because you absolutely have to know it. You probably are not going to work in an area where you're going to see much of this, if any at all. But it's very interesting because as the years go on, since 2012, they continue to update and revise these codes as we learn more about genetics and we learn more about what certain genes do and what they turn on and turn off signals in our body. And so that's why every year we are always going to see new codes and revised codes. This year, some of the new codes are for different types of drug metabolisms. We have ones that are dealing with hemolytic anemia and jaundice. Sorry, when you look at these, you have to really look through them. We have new codes for issues with different types of thalassemias, different types of platelet issues like thrombocytopenias and the purpuras. We also have ones for different issues with gliomas. So again, tumors of the glial cells. And so as we keep going on, we have more and more to look at. But again, these are not ones that you're going to be dealing with in the real world. That does not mean it will not come up on a CPC exam or another certification or credential. That's why it's well worth a read. And again, it's really, really interesting. But along with all of these tests, we have tier 1 and tier 2 molecular pathology, okay? And tier 1 is the more common test that we do. Tier 2 is the least common. Tier 2 has tons of different tests. When you look at the tier 1 codes, like for instance, when I'm looking at code 81375, it's HLA class 2 typing low resolution equivalence, okay? So we're looking at basically one major part. Versus you look at 81400 and it just goes on. We're looking for, it looks like probably 20 different things that are in the body system that we can look for. Coagulation factors, we can look for different types of cytokines, different fibroblastic growths. So those are less often used. And again, they're continuing to be revised as the years go on. And a lot of tier 2 stuff is moving into tier 1. But then we get to what we call genomic sequencing procedures and all other molecular multi-analyte assays, or MAAAs. Okay, and the biggest thing here again is these are more of the tests that have been around for a little bit longer, although they have been updated much more recently. So what it tells us is genomic sequencing procedures, or GSPs, and other molecular multi-analyte assays. GSPs are DNA or RNA sequence analysis methods that simultaneously assay multiple genes or genetic regions relevant to a clinical situation. So that's what's different about these. We're looking at a series of genes or a genetic region of the human genome to try to figure out what's going on. They may target specific combinations of genes or genetic material, or assay the exome or the genome. The technology used for genomic sequencing is commonly referred to as next-generation sequencing, or NGS, or massively parallel sequencing, MPS. GSPs are performed on nucleic acids for germlines and neoplastic samples. Examples of application include aneuploidy analysis of cell-free circulation fetal DNA, gene panels for somatic alterations in neoplasms, and sequence analysis of exome or genomes to determine the cause of a developmental delay. So again, when we're looking at these codes, for instance, code 81412 is talking about and I always pronounce this wrong, so I'm really going to apologize, the Ashkenazi Jewish associated disorder. Examples: Bloom syndrome, Canavan disease, cystic fibrosis, familial dysautonomia, Fanconi anemia group C, Gaucher disease, and Tay-Sachs, and that's what I was saying earlier. So again, different types of testing. For this, we're looking at part of a gene, group of genes that will give us an idea of what might be going on, especially as they're saying in developmental delays. Usually we try not to worry too much if a child is behind in their delays for things like sitting up and walking and talking, but conditions like Tay-Sachs, which is basically their actual movement just gets taken away from them, happens much earlier. And so, if that child starts sitting up at 4 months and now 6 months they can't sit up anymore, that might be something we might want to look into to see what might be a problem. Again, a lot of it is based upon the family history, but we also have different ones. We have things like aortic dysfunction or dilation, like Marfan syndrome, which again is a congenital anomaly. We also have things like 81425 genome, like unexplained constitutional heritable disorder or syndrome, where we don't really know, but we're looking for something. So again, these are tests, again, we're not going to see too much of unless you work for a facility that can actually perform them. Then we get to what we call MAAAs, multi-analyte assays with algorithmic analyses. And these are procedures that utilize multiple results derived from panels of analyses of various types, including molecular pathology assays, fluorescent in situ hybridization assays, and non-nucleic acid-base assays like proteins, polypeptides, lipids, and carbohydrates. Algorithmic analyses using the results of these assays, as well as other patient information, is then performed and typically reported as a numeric score or a probability. So again, what they're doing here is they're taking a whole bunch of different pieces of information and they're trying to put together what is possibly going on with the patient and then looking for that specifically. The results of the individual component procedures are inputs of the MAAs may be provided on the associated laboratory report. However, these assays are not separately reported using additional codes. So again, we're grouping all of this together. Now, the format of the code descriptors of MAAs include in order. So these are the different things we're looking for. We're looking for disease types, materials analyzed, number of markers, the methodology we're using, the number of functional domains, a specimen type, an algorithmic result, and the report, which gives us the probability index and the risk score. So for instance, we have things like 81506, endocrinology, type 2 diabetes, biochemical assays of 7 analytes, which include glucose, HbA1c, insulin, HSCRP, adiponectin, ferritin, interleukin 2 receptor alpha. And it says utilizing serum or plasma algorithmic reporting as a risk score. So again, in that case, we're looking specifically for the probability of this patient to have type 2 diabetes, and in general to look for other endocrine disorders that might deal with the pancreas. So again, these are less often used. These are used usually after the patient has had other testing done to try to figure out what might be going on. Now, as we get to the rest of these sections, some of them are going to have a lot of guidelines, like chemistry, and other ones will have absolutely no guidelines. And so again, one of the big things to think about for Path and Lab is, what are we looking at? Are we looking at something inside the blood? Are we looking at the blood itself, the red blood cells, the white blood cells? Are we looking at the immune system of the body? What are we specifically looking at? And that will help you kind of decide what section you should be looking at. Now, the easiest way to find the codes under chemistry is to go under Pathology and Laboratory, Chemistry. Okay, and that's one of the ones I suggest that you highlight as a subdivision so that you can easily find it. And chemistry goes on for quite a few pages in your alphabetic index. So it tells us the material for examination may be from any source unless otherwise specified in the code descriptor. When an analyte is measured in multiple specimens from different sources or in specimens that are obtained at different times, the analyte is reported separately for each source and for each specimen. The examination is quantitative unless specified. Okay, and then again, to report organ or disease-oriented panels, go back to the beginning. So again, the biggest thing here is what we're doing is we're looking for things that either should be in the blood and how much it is, or shouldn't be in the blood and how much it is. It goes on to talk about the clinical information or mathematically calculated values, which are not specifically requested by the ordering physician and are derived from the results of other ordered or performed laboratory tests, are considered part of the ordered test procedure and therefore are not separately reported. So again, the lab values, when that lab sheet prints out, that's part of it, okay? So they're just reminding us that is the documentation. Now, when the request analyte results derived using a calculation that requires values from non-requested laboratory analyses, only the requested analyte code should be reported. So again, when we're only looking for one thing, we're not looking for all of them. When the calculated analyte determination requires values derived from other requested and non-requested laboratory analyses, the requested analyte codes, including those calculated, should be reported. Again, sometimes you might be working for the lab where people send out the blood to you because you might be a specialty lab. And so again, what are we looking at? What are we specifically doing with that specimen? The exception to the above is when the analyte, like urinary creatinine, is performed to compensate for variations in urine concentration. So again, they're giving us just a little bit of extra information. So when we look at these types of codes, okay, so it starts with things like ketone bodies, which we have to worry about in our diabetics. It has anything you could think of. It has the ACTH hormone. It has aluminum, ammonia, amylase. Arsenic, which again shouldn't be in the body. So that's one of the things we have to think about. Chemistry is not the blood itself, but what is inside the blood, and looking for things that shouldn't be in the blood, like arsenic. If we think someone's been poisoned, we might look for arsenic. We might look for other heavy metals. We can also look for things like bile acids. We can look for vitamin D. And again, most people who are born in the wintertime and people like me who prefer not to go outside most of the time tend to be vitamin D deficient, so our doctors test us for that. Again, that's something that's supposed to be in the body, but they want to know the amount. Things like calcium, as we keep going, it's mostly in alphabetic order. You can kind of look through it. It's also things like, cortisol, cholesterol, creatinine kinase, cyanide. So again, poisons and things that should be in the blood. But again, how much? If there's too much cortisol in the body, that can indicate a problem with the endocrine system. So again, thinking about why are we testing? Again, we have everything from different, like very long chain fatty acids to fructose. We can look for different blood gases. Again, like for instance, if you look at 82803, gases blood, any combination of PO, PCO2, PO2, CO2, and HCO3, including calculated O2 saturation. Again, if the person's having issues breathing, how much oxygen are they getting in? How much carbon dioxide is staying in their bloodstream? Again, we can do this from other body sources. So we have things like gastric acid analysis. So again, we're going in and grabbing the gastric acid. That's what the specimen is. We also have things, insulin, again, lipoproteins, things like manganese, nickel, you name it, it's in here. Anything that, again, is part of our bloodstream normally, or things that shouldn't be in the bloodstream but can get in that we have tests for. And it goes on for quite a long time. And then again, we have other vitamins too. We can look for vitamin A, vitamin K. We can look for things like zinc. We can look for the gonadotropin, the C-peptide. So again, lots of different things in chemistry. So the easiest way, again, is to look up pathology and laboratory, chemistry, and then what are we looking for? What's the name of the substance that we're looking for? Now we get to hematology and coagulation. Again, no guidelines. But again, this is talking about exactly what it says. So hematology, the study of blood. So this is going to be white blood cells, red blood cells, platelets, all the other components that help the bloodstream continue to do its job, and also all the components that deal with coagulation. Okay, so again, these are not only going to be general things like the automated differential white blood cell count and stuff like that. We want to generally know things like that, but also we can look at how long it takes the blood to clot and things like that. Because again, if someone is on like Coumadin or warfarin, a blood thinner, these are things that we have to think about. So again, we can look up all different types of blood smears. It continues to go on. We can look up reticulocytes, leukocytes, platelets, and different clotting factors. That's the other thing. Remember, as I was saying, coagulation. So people that have issues with hemophilia, they have what they call clotting factor issues. So we have clotting factor 1, 2, 5, 7, 8. There's a couple different versions of 8, 9, 10, 12, and 13. We also have clotting inhibitors or anticoagulants. Again, seeing if someone is either on a blood thinner or if there's something wrong with the way their body is producing the blood, so it's not as viscous as it should be. Again, we're looking for things like hemolysin, so we're looking for the breakdown of red blood cells and how fast that happens. So again, when we think about hematology and coagulation, we have to break down the terms, and again, you can find this under Path and Lab, hematology and coagulation. The next section is immunology. So two things to keep in mind. I'm going to make this a little bit smaller so you guys can see it. And it went up quite a bit. That was my fault. There we go. Okay. So when it comes to immunology, we're going to see the terms antigen and antibody. So I always write them around here. Okay, so first, just because of where I had to put it. An antigen is a foreign substance, okay? So anything could be a foreign substance. a bacteria, a virus, a fungi. For instance, when we are exposed to a disease, the disease itself is the antigen. That is the foreign substance that has gotten into our bloodstream. What happens then is our immune system should kick in and produce what we call an antibody. And an antibody is a blood protein that responds to the antigen. So when we are getting vaccinated, what happens is we are given a small amount of a vaccine. It could be a live vaccine, a dead vaccine, or a copy of a vaccine. And what happens is we put that in the body. Okay, that's the antigen. Then our bodies then fight off that antigen and create a blood protein that responds and kills the antigen, but also remembers that antigen. So if it gets into the body again, our bodies know how to fight it off. That's how vaccines work, and immunizations. But again, things can happen, and because of things like parasitic borne diseases, again, things like ticks right here, Rocky Mountain spotted fever, things that are transferred from animal to human, whether it's an insect or like a cat or a dog, or even a rabbit. So we have rabbit fever as well, which can also, it's a bacteria that goes from rabbit to human. So we're looking for all these different things. So in immunology, again, we are looking for different antibodies. We're looking for different types of agglutins. We're looking for different types of immunoassays. And again, we're looking for something in the immune system. What is the reaction? What are we testing for? And a lot of times these codes are looking for a specific disease. So if you get to page 573 in your code book, you're going to see things like antibody, and then they're going to list. And a lot of these are what you're going to find in your infectious and parasitic diseases in chapters 1 and 2 in your ICD-10 book. So we have things like Aspergillus, Bartonella, Bordetella, Candida, Cryptococcus, encephalitis, Epstein-Barr, helminths, which are our worms that people get. Things like Giardia, all the different types of herpes, all the different types of HIV, all the different hepatitises, hepatitis A and B. We also have antibodies for things like leishmania, for the parvovirus, for the respiratory syntactile virus, rubella, tetanus. So again, these are, number one, seeing if it's in your body, and number two, how much, and how's your body reacting. So if you, let's say, got a measles, mumps, and rubella test, because you can't find your vaccination records, okay? This is the area where they're going to test, because they're going to see, are you immune to that? We can also be looking for these diseases as well. So again, we're going back and forth. Sometimes we're looking to see if the patient has it, but we can also test if the patient is immune to it, such as when you get, that's what the titer test is called, for like measles, mumps, and rubella. Okay, then we get to tissue typing. Again, this is going to be for usually our hematologists are going to be mainly dealing with this. We're looking at cross-matching. We are looking at making sure that the HLA typing works. Again, the biggest thing when we're talking about tissue typing is making sure that there's not going to be any rejection. Okay, and so that's one of the biggest parts of tissue typing. Again, no guidelines, but under Path and Lab tissue typing. We then get to transfusion medicine. Again, most of these are going to be different types of blood products, different things that could be in the blood products. So we can do everything from an antibody screen all the way down here. We have the collection and processing of it and storage if someone is going to store their blood ahead of time. One of the big things they started doing probably over 10 years ago, at least in my area, is if patients are going to have a planned surgery, what they can do is they can basically go every month and get a pint of blood taken out of them, and they will store it and freeze it at the facility and then use it for the patient during surgery. So this helps with patients who are worried about transfusions in general. And this is also for people that might have specific religious needs where they're not allowed to have blood products from other people. It also means no rejection because it's your blood. So that's also part of it. So it's the blood typing as well as the storing and the processing of blood as well. Now, microbiology gets to all of our nasty bits. So this is the bacteriology, mycology, parasitology, virology. Bacteria, funguses, parasites, viruses. Okay, so again, they have to tell us what we're looking at. So they tell us presumptive identification of microorganisms is defined as identification by colony morphology, growth on selective media. Gram stains are up to 3 tests, including catalase, oxidase, indole, or urease. Definitive identification of microorganisms is defined as identification to the genus or species level that requires additional tests, such as biochemical panels or slide cultures. Okay, so again, presumptive versus definitive. So presumptive usually means we are taking a sample, and depending on what we think it is, if it's a bacteria, we're going to allow it to grow. We can gram stain it if it's a virus. We can also see if colony growth if it's a parasite as well. And funguses, of course, love to grow. So the presumptive identification is letting it grow and seeing if we can figure out what it might be. Okay, where it fits: viruses, fungi, parasites, or bacteria. Then the definitive identification is finding the exact genus or species, so the exact problem that the patient has. And it goes on that if there are additional studies that involve molecular probes, nucleic acid sequencing, chromatography, or immunologic techniques, these should be separately coded using the 87140 to 87158 in addition to the definitive identification code. So again, these can be paired together for doing a presumptive and definitive because we get paid for doing both. There's work that's involved in both sets of testing. Now, the molecular diagnostic codes are not to be used in combination with or instead of the procedures represented by 87140 to 87158. So again, the 81200 to 81408. So again, they're telling us these cannot be used together. It's an either or scenario. Again, it tells us for multiple specimen sites, use modifier 59. And for repeat laboratory tests performed on the same day, use modifier 91. So again, this starts with things like small animal inoculation. So for instance, if we really have no idea what's wrong with the patient, we might take a sample of the patient and we might put it into, say, a small mouse and see what happens. And if the mouse dies, then we can observe it and we can dissect it. We can also look for, again, all different types of infectious agents, and it's going to go in order. We have everything from bacterial cultures, different types of identifications for different types of fungi, different parasites. We have things like ova and parasite smears. We're going to see things like virus isolation. And then as we get to like page 579, we're going to see things that are those specific probes. So again, what I do is, 87260, these are infectious agent antigen detection by immunofluorescent technique. Okay, and then each of the different techniques I highlight. 87301 is an immunoassay technique. As we keep going through all the different techniques we can use. And we need to know what techniques they're using so that we can make sure we are coding properly for everything that they did for those patients. And again, for this, easiest way is to look under Pathology and Laboratory, Microbiology. We then get to our anatomic pathology. So these are our post-mortem examinations. Again, we need to know how much, what was the extent of it. So again, gross examination only is with the naked eye, okay? So again, if let's say they think the patient had a massive stroke, they take off the skull and they can see a massive brain bleed with the naked eye. Do they need to do any more? No, that would be 88005. Gross examination only with brain. However, when you're thinking more of like the TV shows out there and all the different people who work for, the morgue and all this stuff, they could be doing a lot more. So that's when we're going to see things like 88020, gross and microscopic. So we're looking, into the body to find out what's going on. We also have a full forensic examination, which you see on, NCIS, CSI, Law and Order, things like that, and the coroner's call. So yes, if the coroner is called to the scene, there is a code for that because they have to write a report of what they found. So again, for these, we can look under either autopsy, necropsy, or pathology and laboratory and anatomic pathology. Cytopathology, these are our different smears. Most of these are going to be cervical and vaginal. Some of them will be anal as well. And so again, how are we performing these? What are the techniques that we use? So they have given us a whole set of revised guidelines. And so the revised guidelines, what I did is for each set of new guidelines, I highlighted them in a different color so that I could link back to the guideline itself. So they tell us that codes 88141 to 88155, 88164 to 67, and 88174 to 75 are used to report cervical or vaginal screens by various methods and to report physician interpretive services. Use codes 88150, 52, and 53 to report conventional pap smears that are examined using non-Bethesda reporting. So again, they have to tell us that. We use codes 88164 to 67 to report conventional pap smears that are examined using the Bethesda system of reporting. We use codes 88142 to 43 to report liquid-based specimen processing as thin layer preparations that are examined using any system of reporting. Okay. Goes on, use 88174 to 75 to report automated screening of liquid-based specimens that are examined using any system of reporting. And within each of these three code families, choose one code that describes the screening method. So again, which best describes the screening method? Codes 88141 and 88155 should be reported in addition to the screening code chosen when additional services are provided. Manual rescreening requires a complete visual reassessment of the entire slide initially screened by either automated or manual process. Manual review represents an assessment of selected cells or a region of slide identified by an initial automated review. Okay, so again, we have add-on codes and we look deeply. So if the system pops up with abnormal cells, then we might do a manual rescreen to manually look at the cells and see, are they actually abnormal? Could this be cancer? And again, we need to know how they're doing it. And again, for those, you can look up pathology and laboratory, cytopathology. Then we get to our surgical pathology. Surgical pathology is based off of levels. And so what we do is we match up the specimen itself to the level based on the information they've given us for the diagnosis. So services 88300 through 88309 include accession, examination, and reporting. They do not include services designated code 88311 through 88365 and 88399, which are coded in addition when provided. And those are additional services, additional stains that might be done on pieces of tissue. The unit of service for codes 88300 through 88309 is the specimen. A specimen is defined as tissue or tissues that are submitted for individual separate attention requiring individual examination and pathologic diagnosis. Two or more such specimens from the same patient, like separately identified endoscopic biopsies or skin lesions, are each appropriately assigned an individual code reflective of its proper level of service. So each specimen gets its own code. If they remove 3 polyps and they give specimens, 1 from each of those, then it's going to be the code times 3. Now, service code 88300 is used for any specimen that, in the opinion of the examining pathologist, can be accurately diagnosed without microscopic examination. Again, that's the gross examination only, so that might be done for something like a tooth. Service code 88302 is used when gross and microscopic examination is performed on a specimen to confirm identification and the absence of disease. So as we move up in levels, we are moving up in complexity. 88300 means we don't need to worry about it whatsoever. We're not even looking under the microscope. 88302, again, we're just making sure it's normal tissue. Services code 88304 through 88309 describe all of their specimens requiring gross and microscopic examination and represent, represent additional ascending levels of physician work. Levels 88302 through 88309 are specifically defined by the assigned specimens. Any unlisted specimen should be assigned to the code which most closely reflects the physician work involved when compared to the other specimens assigned to that code. So this is the best way to look at it. 88300 is with the eye only, okay? So again, like a tooth. 88302 is benign and normal tissue. So again, we're looking for the anatomic site. So again, sometimes it's going to be backwards. So for instance, this is foreskin on a newborn, but if they're not a newborn, we're going to have to keep looking. And there is a code that includes foreskin non-newborn. Oop. Sorry. So again, as we go through, 88302 is benign normal tissue. 88304, there is no 88303. Don't ask me why, I don't know. But 88304 is a low occurrence of disease. So again, these are abscesses, these are bone fragments, these are cartilage shavings, things like that. Okay, 88305 is a moderate occurrence of disease. Again, doesn't mean cancer, but there's a moderate occurrence of disease. Okay, so again, we're just matching up body parts as we go through. 88307, which is level 5, is a complex pathology. So again, things like a tumor resection from the brain or meninges, colonization of the cervix. So these are things that, you know, we don't just remove for no reason. So there's a reason, and we want to make sure it's not cancerous. And then 88309, which is level 6, is considered neoplastic and very complex pathology. So again, a mastectomy, a total resection of the colon, you know, a total lobe or lung, you know, resection, a radical resection of the prostate. So again, we're removing body parts. And again, you'll see a lot of these either, we'll say resection or resection for tumor. And again, it's because these are, again, very complex diseases or neoplastic. And so what you do is when you get to surgical pathology, you're looking at what is the actual specimen, where does it fit when it comes to the body part itself. It looks much more complex than it actually is, and you want to keep that in mind. It's really not that difficult. And again, the best way is to go into Pathology and Laboratory, Surgical Pathology, and then you'll see level 1, 2, 3, 4, 5, 6. Again, another set that doesn't have any guidelines, the in vivo, these are the transcutaneous procedures. For instance, 88720, they do this to babies all the time. At the hospital near me, they have like this little wand that they pass over the forehead, and it kind of gives them a bilirubin reading to see what's going on, to make sure. We can also do hemoglobin, transcutaneous. So again, this is through the skin. And so again, we're looking at these specific ones. So things that we can look at bilirubin, we can look at hemoglobin, we can look at methemoglobin, and then we have an unlisted service for any other ones. And again, for these are going to be under in vivo, okay, because we're going through the body. We have a whole series of reproductive medicine. And again, if you end up working for in vitro fertilization, you will use these. This is everything from culturing the eggs, prepping the eggs, transferring the eggs, taking the eggs out of the ovaries, taking the sperm and putting it in the egg, making sure that the sperm has motility, all of these different ways that we deal with reproductive medicine. It usually starts with the man and then moves on to the woman. And then again, if we are doing in vitro fertilization, we are going to be using these codes depending on exactly what we do for that particular person or that couple. And so that's the big thing. And again, for this, we need to know what we're doing. Are we assisting in embryo hatching using a micro technique? Are we cryopreserving embryos? Are we assisting in oocyte fertilization? So again, what's going on? What are we doing in the reproductive medicine? The last set of codes are new, and here they are. They're called PLAs, Proprietary Laboratory Analyses. Now, when you go on the CPT, or sorry, I should say the AMA website for the CPT book, you can get a link to the PLA section. And the PLA section basically doesn't give you much more than it gives you here. This is what I understand. Laboratories that would like to become PLAs, because it is under the Protecting Access to Medicare Act, or PAMA, of 2014, they actually have to go onto the AMA website, they have to go into the PLA section, and they have to apply to be a lab. These are all new codes. These all start with zeros and end in U's. And again, this is something that if you end up working in one of these labs, you may be using. As of right now, I don't know anyone that is associated with a lab that is properly using these codes. So that's one of the big things. So this is specifically for laboratories that are considered PLAs under the Protecting Access to Medicare Act, PAMA. So again, this is something that I don't know if you're going to see out in the field or not, but it could show up on a credentialing test, because these codes are in the book, and anything that's in the book is fair game. And these are going to be under Proprietary Laboratory Analyses, under Pathology and Laboratory as a main term in the back of the book. Remember, Path and Lab looks scary, but in the real world, you will know what your lab can run, what specific techniques, what specific codes we use. And so that way it makes life a little bit easier. When you're simulating it in a classroom or preparing for a certification or credential, you just have to keep in mind, if you need to know more information, write it in your book, and write it where it is in the book, because for most certifications or credentials, you're not looking up a lot of codes in the back of the book. You're going straight to the code. If there's a notation that's going to help you, then it's fair game for the test, and you should absolutely use it. All right, good luck, guys.